milligrams a day. Less than 15, don't go higher than 25 milligrams a day. These are just some examples. You're going to go down the whole drug list, you're going to see things like this and have to change your doses. Remember our recitation case from hypertension and heart failure? It's a 53-year-old guy. He had a serum creatinine, and we said it was 2.99, the baseline of 2. So that was kind of tricky. We kind of like skirted away from that and didn't tell you, didn't address that really, right? So that patient had, let's see, we'd have to plug in our MDRD equation to see if he had CKD. But I'm guessing if you plugged in the MDRD equation with a 2, he'd come up with some stage of chronic kidney disease. But his serum creatinine today, like when he came into that hospitalization, was 2.99. Is that bad? That's roughly 50% increase from his baseline. So does he have CKD or does he have AKI? What do you guys think? Or does he have both? You can definitely have both. All right, so the term we use for this is acute on chronic kidney disease. So he already had chronic kidney disease, but now he has an acute worsening of the kidney disease on top of it. This was a patient from like yesterday, okay? I took this because it pretty much, it looks like remarkably like what the case was. So you can see the normal range tells you high is here, like 1.3 is our lab, I guess. Low is 0.5. So this is a normal range in this limit, this range right here. Baseline, he's at 2. So every single day we do serum creatinine, 2, 2, 2.2, 2, 2, 2, 2, and then the last couple of days, yesterday, 3.1. So this sort of is an example of a patient has chronic kidney disease at baseline where he's stable, stable, stable all week long. If we looked in his outpatient labs, we'd get even more information. And now all of a sudden yesterday he jumps up to a 3. So I don't know what happened today. I'm here, but like tomorrow I'll tell you because I'll be back at the site to see if this comes back. So we have to figure out if he was a little bit dry, a little bit overloaded. The same thing that causes AKI in a non-CKD patient can cause AKI in a CKD patient. Does that make sense? Okay, hemodialysis, I spend very little time on, so I'm going to answer those questions. Hold on. Question about restricting fluid from patients. the fluid restriction for these various kidney conditions is part of your supportive care umbrella. The time you would do that is when they have demonstrated that they're fluid overload. Meaning on physical exam, you could see like they have edema, or you listen to their lungs, they have crackles, they have fluid building up in their lungs. And they maybe tell you they're short of breath, they can't breathe. Or maybe their heart function is not going well because the heart can't pump around fluid. So those patients you may have to fluid restrict. That's part of like your supportive care umbrella, and those are kind of the signals that would make you do that. I hope that clarifies. Can you re-explain the goals for iron deficiency? So iron deficiency is essentially something that you need to make sure is not happening when they're anemic, because that could be number one, the cause of the anemia. And if that's not the cause of the anemia, the ESAs won't work if they're iron deficient. So you need to fix the iron first. So the goals for iron deficiency are in here somewhere. When you order an iron panel, there's not like a nice like shape that it comes in, like our fish, okay? You can order a serum iron, you can order a total iron binding capacity, you can order a transferrin saturation or TSAT, you can order a ferritin. So some of the goals of giving iron are correcting these two. The transferrin, you want a saturation of at least 20%, and a ferritin of more than 100 for these stages and more than 200 for the later stages, okay? When patients' kidney function gets worse, you could have the same amount of iron as someone with no kidney function, but the patient with the CKD can't use it the same. as the toxins build up, it becomes, they limit how they take the iron and use it to actually integrate it to make the hemoglobin. So you shoot for a higher iron level. That's the reason why a ferritin of like 100 if they're not that bad, but 200 as the kidneys get worse, because it doesn't mobilize the same when you have CKD. That's the reason why the goal changes when your kidney disease gets worse. Okay, hemodialysis. Essentially, we have a machine that is a membrane that duplicates what the kidney does to some extent. So extracorporeal, meaning outside the body. So extracorporeal renal replacement therapy. 93% of patients are on hemodialysis. A normal hemodialysis is something that they go to 3 days a week, usually. Most people are on it 3 days a week. You have to go to a hemodialysis center. You sit there for somewhere around like 4 hours, hooked up to this machine, and they filter the blood. There's something called peritoneal dialysis, that they put the fluid into your peritoneal cavity, let it sit there for several hours, and then they drain the fluid out. That's something that they usually do every day, and you can actually do at home. So if you're capable enough and you have the dexterity and you can maintain your peritoneal like ports, you get the supplies at home, you go to sleep, you hang the bag, you wake up in the middle of the night, change the bag to drain your peritoneal fluid out. Much less common in America to use that compared to hemodialysis. Some other parts of the world, they use it more. Okay. Dialysis removes folate, so you end up having to supplement people with folate. You give them a renal vitamin. There's one called like Nefercaps. It has lots of different vitamin Bs in it, and folate, because those water-soluble vitamins will come out with your dialysate. This is an illustration of what happens. You end up getting access to these patients. You can't just put like a little IV like in their hand, okay, to get the fluid out. You have to put in large access. So you connect an artery to a vein, and somewhere up here, antecubital, sometimes higher. This is kind of low, but you should see it up more brachial. So you can do a graft or you can do a fistula. These are different types of accesses where you're putting a large bore needle of the blood coming out to the machine. It goes through the machine and a large bore needle going back into the arm. The fluid that exchanges across the membrane is called a dialysate. And all it does, it's very simple, the toxins go down a concentration gradient. So if your blood has a lot of toxins in it, the dialysate has no toxins in it, essentially it just shifts passively down a gradient. That's the way a lot of diffusion happens. This is a look at a machine. They used to be big, now they're like this big, maybe like at North Shore, they're like up to here. Okay, like this big. You can wheel them around. And see how there's looks like there's like a lump under this person's skin. So that's a graft. This is a special type of access. They put a special line under the skin that stays there for indefinite amount of time, as long as they're on dialysis. So you don't put these things in lightly. They can become problems. They can get infected. Last week we had a patient with an AV fistula. Her blood pressure dropped. And the fistula ended up getting a clot in it. So they had to go address the clot that's in the AV fistula. Perfect timing. Any questions in 30 seconds before Dr. Smith takes over? Yes. Okay, so for the table for the vitamin D analogs, there's several different ones. Paracalcitol decreases PTH, and it doesn't increase calcium or phosphorus. Whereas doxorcalciferol does. It does increase calcium and phosphorus. So in trying to find these balance, those are some of the nuances that are definitely different between these two drugs. You're welcome. If you have any questions about this, be sure to email me, let me know. Good luck. See you guys.